Hi, my name is Sarah Norman, and this is the presentation of the Capstone PowerPoint. I had originally chosen pulmonary rehab for COPD patients, so I actually chose the drug Symbicort as my topic. So Symbicort is actually a combination drug. It is known as a metered dose combination inhaler. It's used in the treatment of obstructive airway disease, such as asthma, and in this case, COPD. Two medications are included in this inhaler. Budesonide, which is a synthetic inhaled corticosteroid, and formoterol is a long-acting beta agonist. This medication is available in two doses, an 80 or a 160, 4.5 grams. Let's see, so the formoterol is going to be, the higher dosage numbers. So the way that this medication works, the mechanism of actions, the outcomes, and all the future information that we go over, it's going to be based upon the two different drugs that are included in this. So this portion will be actually a little bit longer telling about the drugs because we have to split it up as to what each drug does. Like I said, the mechanism of action is based on each medication individually. The budesonide is, like I said, the inhaled corticosteroid. This is part of the medication. The mechanism of action on that is it can control the rate of the protein synthesis, and it decreases the migration of leukocytes, which are white blood cells, preventing inflammation, in this instance, in the lungs. In patients with COPD, lung damage results in swelling and inflammation. We learned, last semester that inflammation and swelling triggers, increase in cortisol in our body, and that leads to glucocorticoid resistance and unregulated inflammation. So you have this inflammation, in your lungs, and because your body is sending out white blood cells to try to fight that, your body just gets bombarded, and you eventually, get resistance, to that, and it's just inflammation is always occurring. This portion of the medication binds to the glucocorticoid receptors in the target cells. So in this case, the lungs, binding to these receptors, it decreases the release of cortisol and ultimately decreases swelling and inflammation. So this medication, once it's used, it goes to the glucocorticoid receptors. It binds to it, so that way your body is sort of not aware that it already has inflammation in it. So that is when the steroid can work on the body and decrease the inflammation in the lungs. Formoterol is a long-acting selective beta-2 antinergic agonist, or a LABA. It provides a rapid onset with bronchodilation, and it helps to maintain symptom control. So when you do that, it is going to help with the dilation of the bronchioles and different parts of the lungs, so that way they're not, open and inflamed. The purpose of this is to maintain the symptoms so they don't feel as short of breath as all the time, and the hope is to reduce the frequency of the COPD exacerbations. An important note is the beta-2s, they also copy the action of catecholamine, such as epinephrine, norepinephrine, and dopamine, and that produces that fight or flight, action in the bronchial smooth muscle, and that leads to relaxation and airway dilation. So it's like if you have a garden hose and it's full of water and it's stretching, once you turn that off, it's going to relax, and water will be able to get through it easier. And again, we're going to split these drugs up separately to go over absorption and distribution. The absorption of the inhaled corticosteroid is rapidly. It's absorbed in the lungs, and the peak concentration is typically within 20 minutes. It did mention on Up to Date that 34% of the inhaled dose is deposited in the lungs, and 39% is available systemic wide. The formoterol, or the LABA, is rapidly absorbed within 5 to 10 minutes. As with many drug products of oral inhalation, it is likely that most of the formoterol is swallowed, and then absorbed from the GI tract. Distribution of the inhaled corticosteroid is 85 to 90% protein binding, so it's going to bind to any of the proteins in the body, and the formoterol is 61 to 64% protein binding. The metabolism of Symbicort, the inhaled corticosteroid, is metabolized by the liver with 39% systemic availability, and the formoterol is also metabolized by the liver. The excretion of the inhaled corticosteroid is 60% excreted by the urine, and the metabolites are excreted by the feces. And formoterol is excreted from the urine as well. Contraindications related to Symbicort. It is not recommended for patients who are taking this for asthma. If their asthma is not well controlled on a long-term asthma control medicine, or requires an inhaled corticosteroid and a LABA as the initial treatment. So when a patient is diagnosed with asthma, if it can't be controlled, like on a rescue inhaler, like a short-term, or a long-term, and it needs that inhaled corticosteroid and the LABA, like we're talking about, this is not a good recommendation for starting it as initial treatment. And as far as COPD, it is not recommended for use in patients for treatment or relief of acute bronchospasms. All the research that I read says that you can use this for maintenance treatment and to help decrease the exacerbations, like I mentioned before, but they're always going to have a backup inhaler for acute symptoms, like an albuterol or something like that. So as with all medications, Symbicort does have some suspected outcomes. The first ones that I have listed are the ones that they found during the study, and then I will go over the post-marketing adverse effects. So with the nervous system, headaches are expected. Respiratory, you can have nasopharyngitis, upper respiratory infections, nasal congestion, laryngeal pain, pulmonary infection, rhinitis, and sinusitis. GI, abdominal distress, which I think everything causes that. Oral candiditis, or yeast infections in the mouth, and vomiting. Infections such as influenza, and neuromuscular and skeletal, it's been known to cause back pain. The post-marketing is a little more in-depth. Cardiovascular, we have angina, atrial arrhythmias, extrasystoles, hypertension, hypotension, palpitations, tachycardia, and ventricular arrhythmias. Endocrine and metabolic, hypocorticoidism, you can see the signs and symptoms of that, like with the Cushing's disease, hyperglycemia, and hypokalemia. GI is going to be nausea, hematological, it's known to cause bruising. Hypersensitive reactions, these include anaphylaxis, angioedema, type 1 reactions, and type 4 nervous system, agitation, behavioral changes, depression, dizziness, nervousness, restlessness, sleep disturbance, tremor, and voice disorders. Neuromuscular are muscle cramps, ophthalmic, cataract, glaucoma, increased intraocular pressure. Respiratory, once again, you're going to have the oral, candidias, throat irritation. I'll discuss some more of these symptoms in depth more whenever we go over the patient education. The special considerations between pediatrics, adults, and geriatrics. It's important that when considering all patients, the dosing is based upon the maximum number of inhalations of the formoterol portion of the medication. So that's going to be the LABA part of the medication and not the steroid. Pediatrics with inhaled corticosteroids, it might cause growth reduction. So it mentions that the dosage should be dosed based upon the lowest effective dosage of the corticosteroid portion of the medication. And that you should monitor pediatrics growth, if they are taking this. In adults and geriatrics, there's no specific listed considerations in either one, but it is important to evaluate the patient's ability to properly use the inhaler. If they can't use it correctly because of dexterity issues or because they're not able to inhale deeply, hold their breath, and get the medication how they're supposed to, there are chambers that can be put on the end of the inhaler. You actually cup the inhaler on the end of it. It's usually like a round tube. You cup the inhaler on the end of it and you squirt the medication into that. It stays in that tube, and then you are actually able to inhale it at that point. It does mention that you need to use in this medication in caution with patients with known cardiovascular disease. In the previous slide, we did go over the fact that it can cause arrhythmias, angina, and serious, cardiac issues. If there is a patient who has those known issues, you want to talk with them, let them know that, review the risk versus benefits, and make sure that the patient's following up, pretty significantly. With diabetes, the steroid part can increase the glucose, so that needs something that needs to be monitored. Any liver impairment, since these medications are regulated through the liver. If the liver's not functioning properly, these medications can build up, and cause that toxicity. Any patients who have known hypokalemia, this medicine does decrease potassium. So a regular, CMP or just a potassium lab is important, to see if, an oral potassium needs to be prescribed. Any type of ocular disease, glaucoma, anything like that, the steroids can increase the intraocular pressure. So regular eye checkups and things like that are definitely important. Seizure disorders, this medication can stimulate the CNS and make seizure disorders worse. And anybody with thyroid disease, if there's a change in the thyroid medication, it may require a change of dose in the Symbicort 2. So that's important, to monitor as well. Okay, so pharmacoeconomics, I did have problem finding some reputable information upon, how much this medication actually costs. I did find one up to date, I'm assuming this is going to be, estimated information. So Symbicort actually has two different doses available, an 80 and a 160 microgram. And then each of those has, the supply comes in a grams, so you're going to have a 6 grams, which is going to be a 15-day supply, or a 10.2 grams, which would be a 30-day supply. And this is based upon whether the patient is doing this, 2 puffs twice a day and things like that. So to start with the 80 micrograms, it says that it's $24.07 per gram. So a 15-day supply is going to be $144 and some change, whereas a 10-gram supply is going to be $245. Keep in mind the 6 grams only covers 15 days and the 10 grams is 30 days. And then we jump over to the 160 dose. Again, that is 31.84. So the 6 grams, remember, 15 days, it's going to be $191. And then the 10 grams, which is 30 days, is going to run about $324. Again, this was updated information from up-to-date, most recent 2026, but it's all going to depend upon, what insurance coverage the patient has. Do they have insurance coverage? Does their insurance, allow this medication? And overall, is this medication, affordable to the patient? There is a generic that is also available, but to be honest, it's not much difference, in overall price. And now that there's a generic, a lot of insurance companies will not cover the Symbicort brand, I have noticed. And then lastly, we have patient education. Of course, we're going to let the patients know why it's being used, the expected, adverse reactions, when to call to the physician's office or 911 if they're having increasing shortness of breath, they can't catch their breath, if their oxygenation drops below a certain, percentage. Signs and symptoms of infection, because, this medication has a steroid in it and it can make you more susceptible to infections. Signs and symptoms of increased glucose. Again, they're going to need to monitor their glucose. It may take 2 full weeks to notice the effects of this medication. Most people expect when they start taking something for it to work instantly, but it's important to remind them that it's not always going to happen. It's going to take a little bit. Make sure not to run out of the medication. That's always important, because your lungs are sort of important, when you're breathing, and if this medication is working, we don't want the lungs, to rebound and then have, an exacerbation. Long-term usage of this, because it has the steroid in it, can cause osteoporosis. So a DEXA scan, over time, and at baseline to make sure that the patient's not experiencing this. We did mention that's increased risk of getting an infection. In COPD patients, it does have the possibility to increase their risk of pneumonia. COPD exacerbations, we see a lot of times people do come in with pneumonia and, just the gunk and junk in the bottom of their lungs, the bacteria, forms that infection. Want to make sure that they are washing their hands, trying to avoid anybody that's sick. And the big important thing, is because of the yeast that this can, cause in the mouth. Each time the patient uses the inhaler, they need to rinse their mouth out and spit, make sure that they get that inhaled. If not, they can get, that yeast, and then that's another medication on top of that. And then the next 2 slides are a list of my references. Some of it came from the FDA, some of it came from AstraZeneca's website, a few articles, and then up to date. Thank you.